Thank you. So my name, as Mark said, is Rose Forster, and I'm a sexual health physician at Auckland Sexual Health Service. And I'm also chairing this update of the PrEP and PEP guidelines, which is just in its very final stages at the moment. How do I... What?
The middle one.
Okay, thanks. So the reasons for the update, the guidelines that we're currently using are the 2021 ASHM PrEP guidelines update for New Zealand, which was initially updated from the 2018 ASHM Australian PrEP guideline. So even though that's only 2 years ago, there's actually been a lot of changes with PrEP in New Zealand, mainly related to the widening of access criteria for PrEP in July 2022. So the guidelines are already quite out of date with that, and we needed to update them to reflect those changes in the special authority criteria. As well as that, we've also had widening of access and prescribing criteria for PEP in July 2022. So before then, PEP, so post-exposure prophylaxis, could only be prescribed by a named HIV prescriber, which was mainly infectious diseases or sexual health physicians. And the criteria to access publicly funded PEP were incredibly narrow, so hardly anyone was actually eligible for publicly funded PEP. Since July 2022, now, any relevant practitioner can prescribe PEP, so that includes people like GPs and nurse practitioners. And there's been a widening of the access criteria for people who can access PEP now. So I think, hopefully, the majority of people now, who would benefit from PEP can now access it, and it's publicly funded. So we haven't actually had a PEP guideline, a national PEP guideline in New Zealand, and generally when we've needed to, we've referred to the ASHM Australian PEP guideline. But now that we have had these changes, it was really important that we had a New Zealand specific guideline as well. So we've developed one, and that's why we're now calling this the New Zealand PrEP and PEP guidelines, because we will have a PEP section in that as well. So the PEP section is an adaptation and an update of the ASHM Australian PEP guideline, the second edition. And while we've all been working on the guidelines, the Australians have actually released their third edition, but we have had access to some of the drafts of that while we've been preparing our own, so that has been taken into account. Just a disclaimer that ASHM has not been involved in the development of the current version of the guidelines for New Zealand, but we do really acknowledge the work of ASHM and the authors in the previous versions that our current guidelines are adapted from, and thanks to ASHM for letting us use their guidelines as a sort of base from which to develop our own. So this is the Aotearoa New Zealand PrEP and PEP guidelines panel, and thanks to everyone who's been involved. So in no particular order, we've got myself as the chair, Massimo Giola, Sarah Metcalf, Rupert Handy, Sunita Azariah, and Brendan Arnold, Edward Coughlin, Tina Matthew, and Anne Robertson, who are all either sexual health or infectious diseases physicians. We've got Hemi Enright and Dane Rua, who are both GPs, who are our Māori representatives, and Hemi also is a public health registrar, I think. And we've got Peter Saxton from the university, Brooke, Cameron and Simran from Burnett Foundation. Dion Reid was our PATHA representative, and our copy editor is Ruth Allen. I just wanted to say thanks to Jacek from Burnett Foundation, or previously from Burnett Foundation, now with the New Zealand Drug Foundation. Jacek was really kind of instrumental in getting this guidelines update started, so thanks very much to him. So when we initially started developing the guidelines, it was done through Burnett Foundation, and there wasn't any external funding for it. But a few months into the process, Te Whatu announced that they had some funding for development of a PrEP guideline as part of the funding from the HIV Action Plan. So there were various discussions, and the guidelines then got moved under the umbrella of the New Zealand Sexual Health Society, and they're now funded by Te Whatu, which is great. As well as funding for the guidelines, there's also funding for implementation of the guidelines as well, and that's work that's going to be done by Burnett Foundation with help from the New Zealand Sexual Health Society as well. So the main changes with the PrEP guideline are in relation to the special authority criteria. So the current special authority criteria are that the patient's tested HIV negative and that the practitioner considers that the patient's at elevated risk of HIV exposure and use of PrEP is clinically appropriate. So these are obviously, it's very broad, which is great. And Chapter 4 of the guideline, which is suitability for PrEP, really talks about who we would consider to be at elevated risk of HIV exposure in New Zealand, and gives kind of various scenarios for different population groups. And because we really want to make sure that PrEP continues to be prescribed for the people who would benefit most. And then, as well as the changes related to the special authority criteria, we've also done an update. We've reviewed the evidence. We've increased the focus on equity, so thanks to Hemi Enright and Dane Ruhr for their input with that. And we've tried to remove more of the gendered language. And we've also specifically included non-binary people in the various sections of the guidance. There's also been a widening of access for PrEP 211, or event-driven or on-demand PrEP. That was mentioned in the previous version of the guidelines, but previously it was just recommended for cisgender MSM and not for other populations. They also, people who are using event-driven PrEP also need to want to use event-driven PrEP, to have infrequent sex, be able to plan ahead for sex, and not be living with chronic hepatitis B. So in line with WHO recommendations, we're now saying that anyone assigned male at birth who's not using exogenous estrogen could, if they meet those criteria, use PrEP 211, and that's regardless of the gender of their sexual partners. And so to make that clearer, we also have a table in the guideline about who could use daily PrEP, which is pretty much everyone, and who might be suitable for event-driven PrEP. So in the PEP section, this is the current special authority for PEP. So PEP can be prescribed by any relevant practitioner. The treatment course needs to be initiated within 72 hours of exposure, but actually, ideally, we want that to happen, within 24 hours or earlier. And then any of the following. So the patient's had condomless anal sex or receptive vaginal sex with a known HIV positive person with an unknown or detectable viral load greater than 200, or the patient shared IV injecting equipment with a known HIV positive person, or the patient's had non-consensual sex and the clinician considers that the risk assessment indicates prophylaxis is required, or the patient's had condomless anal sex with a person from a high HIV prevalence country or risk group whose HIV status is unknown. And I think it's that last category, 2.4, that is going to be the one where most of our patients where we're prescribing PrEP are going to be coming from. So, as I said, this is the PEP section is an adaptation and an update of the ASHM Australian PEP guidelines, the second edition. And one of the things we were thinking about when we were starting with the PEP section was the issue of 2-drug versus 3-drug PEP. So, 2-drug PEP generally consists of tenofovir and emtricitabine. 3-drug PEP is usually tenofovir, emtricitabine, and then another drug, either dolutegravir or raltegravir. And most of the guidelines around the world most of the PEP guidelines around the world, when PEP is recommended, will recommend 3-drug PEP. And the Australian guideline is, I think, really the only one where 2-drug PEP is recommended in some situations and 3-drug PEP in others. And right at the beginning, before I'd really looked into anything, I was thinking, of course we're going to be, recommending 3-drug PEP. If we're recommending PEP, 3-drug PEP clearly must be much better, and, and so on. But when I actually looked into the evidence, and there's not a huge amount, there actually is nothing to suggest that 3-drug PEP is better or 2-drug PEP is inferior. What we do know, though, is that the main thing with PEP is it's really important to start PEP as soon as possible after the exposure for it to be effective. So ideally within 24 hours, but, as early as possible. And, that's really crucial for PEP to work. And that's what we really need to kind of be advocating for. So for that to happen, the community needs to know that PEP is a thing, and that they can ask for it and where to get it. Clinicians need to be aware of it and know how to prescribe it so that they can respond to requests for PEP. And so they can also look for it when someone, if they're taking a sexual history and PEP is indicated, that they can pick that up and offer PEP. And we also need to have a supply of PEP that's easily available. So we need to have pharmacies that are stocking it, and we need to have, in places where there aren't many pharmacies or it's after hours, we need to have PEP packs that can be given out. The guideline is going to have, or has a table of PEP recommendations in it, which is split into sexual exposure and non-occupational and other exposures. The sexual exposure part is on this slide, and the occupational and other on the next slide, just to make it easier to read. For sexual exposures, where the source is known to be living with HIV, if the viral load is undetectable, we are not recommending PEP because we know that U equals U, undetectable is untransmissible. Where the source has an unknown viral load, or we know that it's detectable, where we're recommending PEP, we're recommending 3-drug PEP. Where the source is of unknown HIV status, if the source is from a low prevalence population, we're not recommending PEP. Where the source is known to be MSM or from a high prevalence country, generally 2-drug PEP would be recommended. With occupational and other exposures, generally in the situations where PEP is recommended, we're recommending 3-drug PEP. You can see that in the column with shared injecting equipment and occupational needle stick injury, where the source is known to be living with HIV but is undetectable, we are recommending 3-drug PEP. There's some variation in this in the various guidelines internationally, but our opinion was that even though the risk in that situation is likely to be very low, U equals U doesn't apply to percutaneous exposure, so we still made the decision to have 3-drug PEP recommended there. So the guidelines, the content of the guidelines is finished. It's just with the designer now, and hopefully will be on the New Zealand Sexual Health Society website in the next week or two. One of the other, or the two of the other things now that we're just doing before the project's finished is we're updating the PrEP tool, and we're designing one for PEP as well. So the PrEP tool, and the version on the screen, this is the current one that's available. This is a kind of A4 at a glance kind of guide about like a summary of how to prescribe PrEP, basically. So that just needs a few tweaks to update it to be consistent with the special authority changes mainly. And then we're designing one for PEP as well, so that hopefully, particularly people who have less experience of prescribing PEP can just have a look at that, and it'll be really quick and easy about how to do it.